This will demonstrate the stages of a single visit ferric sulphate pulpotomy undertaken for a vital pulp. The tooth in question is a second primary molar which has deep occlusal caries. If a radiograph were available, it would show very deep occlusal caries in close proximity to the pulp. Local anaesthetic has been given and rubber dam has been applied. The next stage is to start to remove the occlusal caries. Black ink has been used on the occlusal surface of this plastic tooth to show you the limits of the cavity occlusally. A diamond fissure burr can be used in an aerotor with water coolant to gain access to the occlusal carious lesion. Care must be taken when removing the caries to ensure that the walls of the cavity occlusally are caries free. Remember that the caries in this occlusal lesion is deep and we are initially concentrating on obtaining clean walls. I would like you now to imagine that this partially prepared cavity shows that there is still caries around the walls and at the floor, so we must continue. At this stage of caries removal, the floor is looking cleaner. However, as I've been instrumenting the floor, the burr has dropped into the pulp. This indicates, as shown, a carious exposure, which in real life would be bleeding profusely with a vital pulp. If there was no bleeding at this site or very little bleeding, then one must consider that the coronal pulp is highly likely to be non-vital. The next tasks are to ensure that the cavity is caries free and then to go on to unroof the pulp chamber. To unroof the pulp chamber, we use a non-end cutting burr such as an endo-Z burr in the aerotor or a bat burr in the slow handpiece. A non-end cutting burr is used so that we can cut laterally without risking perforation of the often thin floor to the pulp chamber. At this stage, a little more caries is being removed from the walls of the cavity to ensure that the whole cavity is caries free. We must also ensure that the cavity is wide enough in all directions to allow good access to the pulp chamber. And now the endo-Z burr will be used, which is the non-end cutting burr, to allow unroofing of the pulp chamber in a safe way. This burr will be entered into the existing exposure site and then moved laterally. Water coolant must be used for this if one is using the air rotor. As you can see, the burr is being moved in a lateral direction. And the aim is to remove the whole of the roof of the pulp chamber so that we don't have a scenario of a keyhole looking into a larger structure. If the access is small, we run the risk of incomplete removal of the coronal pulp. And as you can see here, we have not yet removed the whole of the roof of the pulp chamber, so we do actually have a keyhole looking into a much larger pulp chamber, so more work is required. More tooth tissue can be removed using the endo Z burr again, or alternatively a very large round steel burr in the slow handpiece. If, however, you do use the large round steel burr, please take care not to instrument the floor of the pulp chamber, as this can be very thin in primary teeth. So the burr should be used in upward strokes along the wall. And as you can see, during this process you will begin to amputate some of the coronal pulp. In the real life situation, this will be very bloody and the field of vision will be poor. Therefore, one must use saline irrigation with an endodontic syringe system. This will safely wash away any debris. Air from the 3-in-1 tip should not be blown directly into the coronal pulp tissue. And the access should be dried using sterile cotton wool pledgets. High pressure air from the 3-in-1 tip should not be used directly into the pulp tissue because we run the risk of causing an air embolism. Further pulp tissue is now removed using a medium or large excavator. And this is worked against the walls of the cavity to sever the pulp tissue. The instrument should be wiped using sterile gauze. Here the excavator is being used to amputate the coronal pulp, and the coronal pulp is removed to the level of the orifices to the root canals. So what you can see here is a partially undertaken pulpotomy. Some of the pulp has been removed, but you can see that we have not yet gained full access to the coronal pulp. Both the ledge of dentine needs removal, and following that, further coronal pulp amputation. Better access has now been gained, and we are now going to check for any ledges using a straight probe. Small areas of ledges are now going to be removed with the large round burr. Further amputation of coronal pulp is now being undertaken using the large excavator. And don't forget to clear your field of vision using sterile saline with the endodontic syringe. Dry the cavity carefully using cotton wool pledgets or a side blow of the 3-in-1. And as you can hopefully see here, we have much better access now to the whole coronal pulp, and amputation is almost complete. So all we need to do now is to remove the last remaining portions of coronal pulp. The coronal pulp has now been removed and you can see the root canal orifices, and I would perhaps, if I was doing this again, remove a little more of the wax to show those orifices a little better. However, we're now at the stage where we can look at this pulp and assess its viability. We are assuming that the pulp we have remaining in this tooth is viable in that it is either normal or reversibly inflamed, and to this end that means that the bleeding in this area should stop within 2 to 3 minutes. At this stage, light pressure can be applied to this pulp with cotton wool pledgets. Following this, ferric sulphate can be applied to the amputated pulp stumps. The solution may be dripped on or placed over the pulps directly using a small pledget of cotton wool soaked in the ferric sulphate, which is then blotted off using some sterile gauze before placement into the tooth. We place the 15% ferric sulphate solution for 15 seconds. And this will allow the ferric sulphate to cause a hemostatic reaction at the cut pulp surface. The ions within the solution join with blood proteins to mechanically block the cut blood vessels. Following the 15-second application, the cotton wool pledget is carefully removed. We then look very carefully at the cut pulp stumps to ensure that bleeding has stopped. If bleeding has not stopped, it may well mean that the radicular pulp is irreversibly inflamed and an alternative treatment needs to be thought about. Some paediatric dentists, however, will apply ferric sulphate for a second time. The radicular pulp stumps will now appear brown and almost charred-like. This is due to the styptic nature of the ferric sulphate. We are now ready to restore the tooth, and the first layer of restoration is a stiffly mixed zinc oxide eugenol lining. This lining is placed in direct contact with the radicular pulp stumps. It is packed into the cavity very gently, avoiding smearing it along the walls. A helpful tip to avoid the lining sticking to the instrument is to dip the clean instrument tip in calcinol or zinc oxide powder before trying to pack the lining into the tooth. One should aim to restore the majority of the pulp chamber using this zinc oxide eugenol cement. Occasionally, a halo of bleeding can occur around the zinc oxide eugenol, and if this does happen, just gently blot away that bleeding with cotton wool. There should be no pulp visible around the sides of the zinc oxide eugenol. The tooth is now ready for definitive restoration with a preform metal crown. The key points for this presentation are that the child must have local anaesthetic beforehand, and care must be taken to remove caries. You must have good access with no ledges overhanging the pulp chamber so that you can undertake complete coronal pulp amputation. We must also be very careful and look at the state of the radicular pulp stumps following coronal pulp amputation to ensure that they stop bleeding within 2 to 3 minutes. Following this, we apply a haemostatic agent, in this case ferric sulphate, and after this application, bleeding must have stopped. We are aiming to retain the radicular pulp vitality. Once the pulpotomy has been undertaken, we want to then restore the tooth with a durable, well-sealed restoration and monitor this tooth for normal exfoliation.